This is our third annual Black History Month event, and we've done these in conjunction over the 3 years. Which is our local TV station and communications organization. This year, we're combining our efforts with an effort from the town of West Hartford called Community Conversations, of which we've done 2 already. And it's sort of the same cast of characters and some others that help us put that together. And this year we're combining with that effort, and West Hartford's having wonderful conversations amongst the community on very interesting and important and informative topics for our community. I'm honored and excited to be here this year and again talk about Black History Month, which I have a lot of passion around. And I just want to make sure that people understand, often Black history is either omitted or miscommunicated. And it's important that people understand that's not by accident. When you look at the history of what we teach in our school system, the people who put together our curriculums were very intentional about who we taught about and who we did not teach about. And when we did teach about people, particularly Black people, there was a narrative that was prolific and was very much intentional for the times that we were in. Again, I've said it many times, as public education became free and also at one point mandatory and is now mandatory, that was during a time that this was happening where Black people were being lynched at a rate of 2 per week. So you can imagine what the environment was like. Unfortunately, we haven't updated our curriculum. But if we think now that things have changed, it's important that you understand something about Black history and specifically about the 1619 Project. There's 3 states already, and probably more to come, in the United States that have bills going through their legislature to prohibit the teaching of the 1619 Project in school systems. Those states, you may not be surprised, include Mississippi, Arkansas, and Iowa. So it's important that we create venues where people can get information. People might argue that the 1619 Project is more journalism than it is history. I propose you read it and you decide for yourself. But I think it's very important that we have the kind of conversations we're having right now. As you may know, the 1619 Project specifically covers many, many different areas, but specifically covers healthcare. And in the time that we're in, we thought it's particularly relevant that we have a conversation about 1619 Project, race, and healthcare, and all of those connections. So it's an important topic. I'm super excited about it, and I'm super excited to have the panelists that we have today. I will tell you the format of the program is going to be about an hour and a half long. First, we're going to talk a little bit about the 1619 Project in general, and then how it goes to race. And then I will ask each of our panelists a question. They'll answer the question, then we'll allow for some panel discussion. And then I think we'll have time for 1 to 2 questions to pose to the panelists. To the extent that we have those questions, we'll ask them in real time when we're on the topic. But if we have time at the end, we could also add some more on those topics. So that'll be the format that we go through. With that, I want to turn it over to Jen Matos. She's the Executive Director of the Noah Webster House and West Hartford Historical Society, and a wonderful partner who's been working on these programs for us. And she will introduce our panelists. Thank you, Jen.
Thank you, Earl. It's just such a pleasure to work with you and WASCO and to help everyone learn more about the 1619 Project. As Earl mentioned, we did a conversation about the 1619 Project last year, and it's really great to be able to go back to it and dig a little deeper into a specific area. And I'm so pleased that we have so many wonderful panelists with us tonight. I'm going to first introduce Dr. Reginald Eady. Dr. Reginald is an accomplished and innovative leader in transforming healthcare and patient care to meet the needs of the 21st century. He was born and raised in Detroit, Michigan, and began his journey towards becoming a physician, a career goal he established at the age of 7. Dreams do come true, as Dr. Eady is a board-certified emergency medicine physician. He earned his Bachelor of Science degree with magna cum laude honors from South Carolina State University. Following undergrad, he returned to Michigan to earn his medical degree from Wayne State University School of Medicine, and he also attended the Michigan State University Broad Business School, where he received his executive MBA. So he currently is the CEO of Trinity Health of New England as president and CEO as of April of 2018. And he now considers himself to be a true New Englander. So how do you like the weather?
Better than Michigan, I'll tell you that, Jen.
Okay, good. There you go. Next, I'd like to introduce Dr. Takesha Dwan Everett. Her passion for social justice was fueled by her own personal experiences and influences as a child. As a youth, she experienced delays in diagnosing asthma and faced challenges accessing and navigating the healthcare system. These experiences gave Dr. Everett firsthand knowledge of the importance of health and healthcare access. This, combined with her admiration for social justice trailblazers such as Thurgood Marshall, Barbara Jordan, and Sandra Day O'Connor, inspired her to dedicate her life's work towards eradicating healthcare inequities through advocacy and policy. She has built a successful career in public policy, particularly healthcare policy and advocacy in the nonprofit, state, and private sectors. Before taking the helm of the Health Equity Solutions, where she is now, she served as the managing director of federal government affairs with the American Diabetic Association, where she provided strategic leadership on policy and advocacy initiatives with the White House, several federal agencies, and Congress, which led to important victories for people with and at risk for diabetes. She earned her doctorate in sociology from American University with a concentration in race, gender, and social justice as it relates to social policy. She received her Master's of Public Administration degree from the Center of Public Administration and Policy at Virginia Polytech Institute and State University, also known as Virginia Tech, and holds 2 Bachelor's of Arts degrees in political science and interdisciplinary studies at the same institution. I'd also like to introduce Mr. Gregory Jones. Oh, I'm sorry. I didn't skip mine. There you go. Mr. Gregory Jones, who's Vice President, Community Health and Engagement for Hartford Healthcare, which is a $4 billion integrated healthcare system in Connecticut. He's responsible for developing programs and investments addressing the social determinants of health. He was responsible for developing the Wholesome Communities Partnership with Wholesome Wave and Hartford Healthcare. Wholesome Communities fights nutrition insecurity by developing and deploying programs to address the lack of affordability and access to healthy food. He is the executive sponsor for the Diversity, Equity, and Inclusion Council, along with serving as the co-chair of the Supplier Diversity Council for the system. Throughout his career, he has been successful in helping companies directly and indirectly translate social conscience into improved profitability. He has a very long resume, so I'm going to truncate it a little bit. He earned an MBA from the Wharton School of the University of Pennsylvania, a master's in public management from Carnegie Mellon University, and a Bachelor of Science degree from Morgan State University. And he is currently serving as the head of community health and engagement for Hartford Healthcare. And last but not least, I want to introduce Dr. Lynn Hayes Thomas. Dr. Lynn Thomas received her bachelor's degree in mathematics from Michigan State University and her medical degree from Duke University. She was in private OBGYN practice in Putnam, Connecticut, and then hospital-based practice at UConn. The last 15 years of her career were spent part-time at York Correctional Institution, from which she retired in 2014. She lives in West Hartford and has lived here since 1992 with 2 children and 2 grandchildren. In addition, as you see here, she is also a member of WASCO, RARE, which is Roosevelt Alumni for Race Equity in Seattle, Washington, and is a junior warden at St. Stephen's Episcopal Church at Bloomfield, and most recently joined the West Hartford Greater Together Advisory Board. So we are really privileged to have all of you here tonight. Thank you for taking the time to join us to talk about this important topic.
So I'm very excited. I've heard most of these panelists speak before, and I just think we have a wonderful discussion in store. First, I'm going to turn it over to Dr. Lynn Thomas, who's going to explain the legacy of racism in healthcare. Dr. Thomas.
Good evening, everyone. Thank you for the invitation. I'm going to pivot a tiny bit. It's going to mostly be the effect of racism on health, but there will be references to healthcare, and I'm sure my other panelists will tie up the loose ends. But I was struck by a statement made in the Berkeley Conversations on Health Inequities that said Black people are living sicker and dying sooner. They restated that, and it said, Black people are living sicker and dying younger. Many towns across America have, including West Hartford, have declared racism to be a public health crisis. I found that to be a powerful statement, and I tried to piece it together. As a few definitions, a public health crisis can be defined as a situation or disease that affects people in a geographic region, which goes on to spread globally. It impacts the economy, loss of life, and health. It can be due to disease, natural disaster, industrial mishap, or poor policy. Health inequity occurs when barriers to good health are avoidable but remain in place. Slavery has been around since man began warring against man. However, it was Prince Henry the Navigator who first declared sub-Saharan Black Africans to be beasts and unchristian, and therefore worthy of enslavement. This notion of white superiority was brought to the shores of America by the English settlers. The racism that we discuss this evening is that of anti-Blackness. A little disclaimer, the impact on health that will be discussed this evening occurs to some extent among all marginalized people. However, our focus tonight is on African Americans. I identify as Black, and I'll be using the terms interchangeably. There is a pervasiveness of anti-Blackness in America. In order to justify enslavement of Black people, those people had to be made to look upon as uncivilized, inferior, undesirable, unworthy, dispensable, less than, as beasts, other. This theme is the basis of America's approach to Black people since they set foot upon the soil. People like Harvard's Louis Agassiz was one of the scientific racism advancers and presented graphic evidence that Blacks were a different species than whites. Around the same time, the middle of the 1800s, a physician, Samuel A. Cartwright, declared that Negroes had smaller brains and blood vessels. They had shorter necks, darker bile, blacker blood, flatter feet, and different skulls. They were childlike, and enslavement was for their own good. After the dissolution of slavery, to further justify handcuffing Black people, there was a doubling down of this stamp of inferiority. Consider more recently Larry Snyder, coach of the esteemed Jesse Owens, winner of 4 gold medals in Hitler's 1936 Olympics, who said in explaining the success, it was not long ago that his ability to sprint and jump was a life and death matter to him in the jungle. Dylan Roof in his manifesto stated that Negroes have lower IQs and lower impulse control. As a result of this long-seated derision, Black people have been exposed to a lifetime of risk. So number one in that public health crisis is economy. As we look at the economic fallout of systemic racism, we see that the financial status of Black people in America was thwarted from the very beginning. Slavery, followed by Jim Crow and Black codes, collectively ensured that Black labor would be cheap or free. Jim Crow denied voting rights, jobs, education, healthcare, and land ownership. That, along with Black codes, detailed where Black people could work, for how much, and for which federally funded programs they would be eligible. Black people were relegated to jobs in the agricultural sector, and it is no coincidence that overtime pay and unemployment insurance have traditionally been denied to farm workers. It made employment difficult and unemployment a crime, punishable by imprisonment and harsh servitude to landowners. As a direct result of this, Black people have been unable to accumulate wealth. Home ownership is the most common route to that end, and because of redlining, Black people were systematically excluded from home loans, neighborhood choice, neighborhood improvement, and were subjected to predatory mortgage practices. Black veterans returning from World War II were not eligible for GI Bill home loans. In many cases, Black people were violently relieved of their wealth. Examples are Mr. Elmore Balling in Lowndersburg, Alabama in 1947, a farmer, employer, shop owner, businessman, and worth about $500,000 in today's money. He was taken out to the road and shot and killed. His property and wealth were stolen, his family was run out of town, and his employees were left to fend for themselves. Someone later told the newspaper he was too successful to be a Negro. After Reconstruction ended and former slave owners were able to return to business as usual, Black people lost millions of dollars with the disintegration of the Freedmen's Bank. In Wilmington, North Carolina, 1898, dozens of Black people were murdered and 2,000 were thrown off of their land. The very successful and thriving community of Greenwood, Tulsa, Oklahoma, also known as Black Wall Street, was attacked over 2 days in 1921 by a white mob with the help of city officials. The massacre left 300 people dead and thousands of homes destroyed. The ripping apart of the Black family, which began with the plunder of African bodies from the homeland and occurred literally countless times during slavery when family members were sold away from each other, has severely impacted family cohesiveness and growth, both socially and financially. It continues today with mass incarceration that is supported by the system of bail that allows people with money to return home, as well as racist legal practices and sentencing laws that disproportionately affect Black people. As a result, there was no intergenerational wealth. Each generation started from scratch. If you take a middle-class Black family and compare them to a middle-class white family, you will find that the white family has assets, wealth accumulation, and far less debt. Education, as you know, is a driver of income and wealth accumulation. As schools became segregated and then dependent on local funding, i.e. property taxes, those in the Black communities were underfunded and substandard. Black students today are more harshly penalized for infractions and are suspended at a much higher rate. When in the same school and class, Black students may not receive the same encouragement to succeed or be placed in gifted or talented classes at the same rate because of conscious or unconscious bias born of stereotypes. This stymies future potential for generations in terms of higher education, higher earning potential, income, and wealth. Today, a Black woman with the same credentials as a white man earns 70 cents on the dollar, and Black women are the heads of 70% of Black households. The economic impact of racism goes beyond the African American community. In September 2009, the Urban Institute determined that Medicare could save $15.6 billion a year if the disparities were eliminated. When they looked at African American and Latinx populations and honed in on the preventable diseases of diabetes, hypertension, and stroke, they concluded that if the prevalence in those two groups was reduced to the same level as in the white population, $239 billion would have been saved alone in 2009. Number two in the triad is loss of life. Racism's impact on the loss of life is inherent in the Middle Passage, where 15% of the human cargo perished. During slavery, the only crime punishable by death for a white man was the murder of another white man. There were 69 crimes for which enslaved persons could be executed. Between 1882 and 1968, 3,446 Black people were lynched in America. The flu pandemic of 1918 killed over 500,000 Americans, but the number of white people who died was less than the number of Black people who died every single year prior to that. Katrina led to devastation and death among the largely Black community due to poor preparation and lack of an evacuation plan. Black males are 3.5 times more likely to be killed by police. Black mothers are 3 to 4 times more likely to die from pregnancy-related illness, and Black infants are twice as likely to die during their first year of life. Life expectancy for African Americans is 72 and 78 for white people. Number 3 in the trilogy, health. The social determinants of health are determined by where we live, work, learn, worship, play, and access healthcare. As a result of systemic racism, Black people are overburdened by hypertension, chronic lung disease, which includes COPD and asthma, diabetes, heart disease, obesity, cancer, and maternal and infant morbidity and mortality. Adequate and healthy housing is essential to psychological and physical health. It needs to be free of radon exposure, peeling paint, rodents, insects, as well as the harsh chemicals that are used to fight them, faulty or exposed wiring, and plumbing issues. It needs to have heat and safe water, unlike that which occurred in Flint. And it needs adequate cooking facilities. Many options have been severely limited to Black people because of the aforementioned legislation. Very quickly, toward the end of the summer, I went with a friend of mine to a friend of hers in Farmington, and she kind of lived in a development. So we were on the highway, and then we got off of the highway. We were on a 2-lane highway, and then we turned off into a street, and then that street entered a lane. And the moment we entered the lane, it became shady, and the trees just seemed to become more and more dense. And as we went farther in, houses began to appear in the tree, within the trees. And by the time we arrived at her friend's house, it was so much darker than it was on the highway because of all its shading. And when we stepped out of the car, it was cooler than it was when we started. And I remember thinking to myself, I bet these folks don't have to pay a lot for air conditioning. Well, come to find out, neighborhoods located near polluting industries and with less green spaces and more concrete are hotter than other residential areas. The amount of concrete in a neighborhood is directly related to the temperature highs in that area. This lack of green space exists in many lower socioeconomic communities. Many Black people are less likely to have air conditioning or the money to power adequate fans. High temperature exposure in pregnancy can lead to adverse effects on development, brain growth, and vulnerability to disease in the newborn. Higher rate of stillbirth also occurs. Food is essential to life. People who live in inner cities or segregated communities are often deprived of easy access to nutritious foods because of the distance that they would need to travel. Yet fast food, liquor stores, and convenience stores abound. Zoning, which determines where businesses and things such as supermarkets and parks will be located, have disadvantaged communities of colors. Jobs that were plentiful have moved to the suburbs, which can pose transportation issues. Yet waste treatment, coal-powered plants, and refineries are seen disproportionately more in or near Black and Brown communities. Communities of color are often bulldozed to make way for highways, which scatters communities and impacts the environment by their very construction. And further, through the polluting emissions of the many and varied vehicles which then travel through. When local governments have budget shortfalls, they institute what is called planned shrinkage. This tends to remove supportive services in communities of colors, such as hospitals, libraries, fire stations, and post office. Occupations are immediately related to income and standard of living. The American workplace has never been on an even playing field, and Black people have traditionally been the last hired and the first fired. Even Woodrow Wilson, once he took office, mandated that the federal workforce become segregated. This led to the firing and demotion of Black civil servants and failure to hire qualified Black candidates. This reduced the income of Black civil servants and bolstered the income gap between Black and white workers. A significant percentage of today's essential workers are Black and people of color, and these jobs tend to lack flexible scheduling, paid sick leave, paid family leave, livable wages, health insurance, or the ability to work from home or quarantine. Studies have shown that Black patients have better health outcomes when they receive care from Black healthcare providers. Yet the Flexner report, which sought outwardly to standardize medical education, declared Black people incapable of being trained as doctors and further resulted in the closure of half of the medical schools in the country and reduced those that were available to Black people from 7 to 2. This legacy continues today, and only 5% of physicians in America are Black. Interestingly, if all things were equal in terms of health coverage, the Black patient may well still receive different care than their white counterpart. Conscious and unconscious bias on the part of the caregiver can impact the outcome. Black people have twice the number of amputations, have less cardiac care procedures or transplants, have less dialysis or kidneys transplants, and receive less treatment for strokes, cancer, and AIDS. Black infants in NICUs with the same diagnoses as their white counterparts have worse outcomes. As a small child, did you ever come up behind your grandmother's chair and go, "Ooh," and she jumped and she said, "Child, you took 5 years off of my life"? Well, there's something to that. There is a concept of allostatic load and weathering. This states that chronic exposure to stress causes greater wear and tear on the body's adaptive systems. This was found to happen in African American women during their reproductive years, and that this deterioration happens more rapidly than in white women. In support of that concept is that African American women under 20 years old and Black women from other countries who arrive in America as adults have better pregnancy outcomes. They have not had the extended length of exposure to anti-Blackness. The role of chronic stress in health is impactful. A chronic state of heightened awareness or alertness, i.e. stress, can cause immune system suppression, digestive disorders, affect the growth process, and lead to anxiety, depression, headaches, heart disease, sleep disorders, weight gain, impairment of memory and concentration, and stroke. This stressor need not only occur to the person individually, but when someone they know experiences it or they see themselves reflected in it on the evening news. Think George Floyd, Ahmaud Arbery, Breonna Taylor. I cannot tell you how many people, including my son, told me they wept when the assailant of Trayvon Martin went free. In a quote from the article from the Center of American Progress, research links maternal depression and anxiety during pregnancy to a higher risk of obesity and diabetes among offspring. Sometimes you're kind of behind the 8 ball before you're even born. Leal Liverpool found the association between low socioeconomic status and racism and gender discrimination to be psychological stressors, and were associated with a decline in kidney function in Black women over time. Chronic stress from racism alone can cause the onset of illnesses such as hypertension and diabetes 7 to 10 years earlier than in cohort populations. Adverse childhood experiences, sorry, I'm a little off here. Disproportionately seen in Black children affect long-term health in terms of mental illness, drug use, and self-harming. I will wrap up my comments here by saying, whereas the health community was taken aback by the devastation that COVID-19 has wreaked on BIPOC communities, it did not come as a surprise. And regarding slavery and racism, I will offer a quote from Dr. Marcella Nunes Smith, who said, "Whereas it is our legacy, it need not be our future." Earl.
Thank you, Dr. Thomas. The reason why I had asked Dr. Thomas to speak is because I've heard her speak before, and there's nobody I know who can share so much knowledge in 15 minutes as Dr. Thomas. So, and it really does show how intertwined racism is with so many other areas of life, including healthcare. So I did want to let our guests know, if you have a question, you can go to the bottom of your screen. There's something that says Q&A, and you can type in a question. And I may have time to ask one or two per panelist. But now I want to open it up and ask if any of the panelists have anything to add or any perspectives to lend to the discussion that we just had with Dr. Thomas. Okay.
I feel like what else can be said?
That was a lot, and it's just so informative. We do have a question from the audience that I'll pose to Dr. Thomas, and certainly anyone can add. What was the name of the study that helped to close the medical schools?
It was the Flexner report. I can't give you the date. It was the early 1900s.
Fantastic. All right. Then, if there are no more questions, I'm going to go to Keisha. All right, Keisha, if you can please, or Dr. Everett, I should say, please talk to us about the link to current disparities in healthcare faced by communities of color.
Absolutely. Thank you again for the opportunity to be here with you all tonight. And thank you, Dr. Thomas, for that wonderful, thorough, and accurate historical grounding on where we are and how we got to where we are as African Americans, Black people in the United States in healthcare. I want to just say as a preface, I am a Black woman. I identify as Black. I will be using the term Black. I am focusing completely on the relationship of African Americans or Blacks as it relates to healthcare and healthcare disparities in the United States. And that's the grounding of my conversation. The pieces that I'm pretty much just filling in, because again, Dr. Thomas did such a wonderful job, is I want to start through thinking about the evolution of the healthcare system and the relationship of that healthcare system to Blacks in America. First and foremost, we begin with the slave system, which was a slave healthcare system, which was designed primarily to keep the slave workforce up and mobile and working for the masters. So when you think about this, this was not at that time when people had the luxury of having private doctors who were coming to their homes and caretaking for them. There were few doctors and mass opportunities periodically throughout the year to ensure the health of the slave workforce. Now, this is already an inequity and an inequality in the type of healthcare that is being provided, the availability of healthcare. And we see in this already the brilliance of the enslaved individuals who started to begin to bring their own healthcare rituals and systems into their own ways of being, to make sure that they were able to ensure for health. This is when we start to see our first doulas in the African American community and midwives who are birthing babies and birthing families birthing babies and taking care of women in their health, even without the formal medical training and the ability to have it. And we fast forward and we're now in free time, and we have the Freedmen's Bureau, and we have our first opportunity to have a federally funded or federally sponsored, if you will, healthcare system. But here again, we have an inequality and an inequity here, where there are about 120 doctors who are now servicing over 4 million people during a smallpox outbreak with very little opportunity to effectively treat all of the individuals who needed to be treated. We are also seeing the inability of the United States to, I shouldn't say inability, the unwillingness of the United States government to provide to provide the healthcare and the resources that are necessary to control smallpox in the African American community. So we see one of the first times that a virus is decimating and destroying the community. Now, this should sound a little bit familiar to current times. That's probably the most wittiest sarcasm I'll give related to COVID-19. But you can literally look at the smallpox epidemic and what happened to African Americans and the difficulty in getting treatment, and look into where we are in contemporary times at what's happening in the COVID-19 pandemic. But that's not what I'm here to talk about. Let me move forward. So then we move into thinking about the difficulty in having it in the where you get your health care. So we had a system that was set up where there were segregated hospitals. And if you were Black, your opportunity to go to a hospital to get health was relegated to public institutions. Now, I always have to tease this out very carefully because it makes it seem like I'm saying private institutions are better. That's not what I'm saying. Let's follow the money. Public institutions that were segregated and only allowed for Black Americans and other people who were non-white were often under-resourced and underfunded. And so the ability to actually take care of the individuals who were coming in at higher volumes with higher exposure to different issues was very difficult. And this is the cycle we continue to go forward when we look at the difference between public hospitals today or hospitals that were formerly public hospitals that have now become private. And again, the ingenuity of the people comes in because now, even when we're having segregated hospitals, we're having immense fights between the American Medical Association and the National Medical Association, which for those who are not familiar, most professional organizations that start with national are Black organizations that were started because African Americans were not allowed to join the mainstream organization. So we're having fights in the United States to prevent people from getting into integrated hospitals, preventing us from getting integrated universal health care, which for many people who don't know, the fight for universal health care dates all the way back to 1945 and has everything to do with anti-Blackness as to why we do not, and to this day, have universal health care in the United States. Again, that might be something to talk about in the Q&A. But the ingenuity of the people comes in because now we start having clinics that are for us, by us, within communities where doctors who are trained, African Americans who are trying their best to care for people have stood up clinics and have funded them and are now providing the health care that is necessary and needed. But when we, again, follow the dollar, clinics are historically underfunded and under-resourced. There's no difference in the care that is giving. There's no difference in the outcomes that are expected, but there is definitely a difference in the resources that we have poured into the clinics. And that's, again, directly related to the evolution of how our healthcare system has been designed and where we're going and how it has continued to flow. When I bring all of this together, this two-tiered or multi-tiered system of healthcare delivery, paired with what Dr. Thomas has talked about, the communities where individuals were relegated to live and what were happening resource-wise in those communities, leads us to seeing the vast health disparities we see and the vast healthcare disparities we see. It is no wonder that many African Americans today are connected to and understand historically and in contemporary sense, the difficulties in trusting the healthcare system and the difficulties in getting the healthcare that they need. Now, I don't want to sound like I don't believe in hospitals or that I don't believe in healthcare delivery. I would dare say Dr. Edie and I are friends, and I would dare say the same about Greg Jones, both of whom work in hospitals. But the bottom line is this: we cannot divorce history, and this is what the 1619 Project allows us to do. We cannot divorce history from our contemporary times. If we do, we are destined to repeat it. And I think when we look and analyze over the next couple of years, when we look back at what has happened in 2020 and 2021 related to our global pandemic, we will see that we are recreating and reproducing some of the same vast inequities that started all the way back in 1619. So what I love about this conversation we're having tonight is that we are able to walk the line of history very quickly and briefly, because we don't have hours and hours and hours to go through all of this, but we're able to walk the line of history and make the connections to the diabetes, the asthma, the under-resourced communities, the social determinants of health, the structural and institutional racism that we see today that's really impacting the health and health care of African Americans. My last point that I want to say before I turn it back to Earl is to say this. Do not be confused about why we have the vast inequities we see. We have had a history of anti-Blackness driven racism in our country, and that hurts everyone. Yes, it disproportionately and primarily impacts and affects African Americans, Black individuals who are born, raised, and or migrated into this country forcibly or voluntarily at any given time throughout our history. This is what we have to make sure that we understand that. But at the same time, it is not helping any of us to continue to reproduce these inequities. We have the power to dismantle the hold that racism has in our health and healthcare system. The last point I'll make is because I've been saying this a lot lately, and I truly believe it. No matter who you pray to or who you don't pray to, if you believe there is a spiritual realm, believe this: the spiritual realm did not create the differences that we continue to foster based on race and racism. Since that is the case, man made it, man can unmake it. We have the power as humans who care deeply about each other to dismantle the effect and impact that racism has on the health and healthcare of African American individuals in the United States, in the state of Connecticut, and specifically within West Hartford. I thank you again for the opportunity tonight. I look forward to the Q&A. And Earl, I turn it back to you.
Thank you, Dr. Everett. That was wonderful. I do have a couple of questions from the audience, but before I go there, I do want to give the panelists the opportunity to add anything or add any reflections. Okay, I'm going to go to a question. So it says, can you briefly talk about similarities between the smallpox breakout and now the COVID-19 pandemic?
Sure. So what I'll say quickly is the one of the things that we say in shorthand about COVID-19, when we talk about why we've seen some of the impact we've seen in communities, is we'll shorthandedly say people live in congregate housing or multi-generational homes, that we are overexposed in essential workers. All of this is related to the history of slavery and freed people in the United States. When we look at the smallpox, what we saw there is because of the newly freed individuals, the lack of economic stability within the African American community, the lack of actual livable and living wages in the African American community, you saw multi-generations of people sharing housing because there's no other way to afford it. There's no other way to live together. This is a historical thing that continues to go through every opportunity that you see, the migration of the South, of individuals from the South to the North. You move in patterns, you move together because that makes things affordable. You also have the inability to have the opportunity for multiple jobs. So it's really, I have to shout out and say right now, if you don't know the history and the story of Dr. Rebecca Crumpler, it's super important to understand who she was and the impact of her in the medical system, being the first African-American woman to be a doctor. That was a limited, there was a limited supply, there was a limited opportunity for people to actually be in the healthcare field or any of the field where you had professions that gave you, that we call or deem the ones who make income, I guess, or the higher income levels. So when we make that connection, we can see some of the same patterns occur today. You have overconcentration of poverty, overconcentration of apartment housing or congregate housing, or these different things in different neighborhoods where we see the vast impact of COVID-19. You also see an overrepresentation of individuals in the front line of healthcare, but also in the front line of keeping our economic engine going as a society based on the historical and, again, the contemporary context of race and racism in America. So that's as quick as I think I can do it. I probably left some stuff out.
Wonderful, thank you. Okay, so a second question from the audience, and I'll put this to all the panelists, even I might have something to say on this one. It says, can you discuss how the history of healthcare disparities ties into the current healthcare issues regarding COVID-19 and vaccines?
You know I'm gonna call on you, Dr. Edie.
He's been mighty quiet. I'm surprised so far.
Well, we had two experts to precede me, so it's difficult for me to add anything. So I'll take a stab at this though. So when you think back, and Doctors Thomas and Everett alluded to it, to things. I mean, the north end of Hartford is the north end of Hartford by design. So when you think about redlining, the Housing Act, the 1960s Highway Act. And incidentally, just as every so-called Black ghetto has a Martin Luther King Boulevard, that is all by design. And so when you look at the locations in which the design has marginalized certain populations in certain geographic locations, you also are looking at areas where the soil is polluted, the air is polluted, the water in many cases is not as clean as others. You see higher incidence of respiratory diseases like asthma or COPD. You see access to ideal healthcare is challenged. That's all by design. And so when you fast forward to what's today, February the 25th, 2021, nothing has changed because the system has been put in place so that, like a chemistry equation, you always get the very same outcome. And then it's not by coincidence, I'll end with this, that when you look at the hotspots, not just in Connecticut, but you look at the hotspots across the country, those are the same areas that the system has produced. We just weren't smart enough, many of us, to understand that 100 years after the last pandemic, we will see the same things happen. We can go back to the conversation we had earlier with smallpox. But the next pandemic that we have in 100 years or sooner is going to produce the same outcomes if we don't, as Dr. Everett so eloquently suggested, make a change as a human race. And so this is by design. I think I'll get a little bit more into it from a COVID and healthcare perspective, and I'll stop there and zip it up.
Okay, so there's another question that I'm going to hold because I think Dr. Edie is going to talk about it, but I do want to make this specific. Let's talk about West Hartford. There was an article in the paper within the last week. Our town historian, Tracy Wilson, was quoted in it, and it talks about the history of segregation in West Hartford. This is not something that's 100 years ago. This is 1970s, during my lifetime and my childhood, where we had zoning laws or practices, in addition to just blatant racism, that made West Hartford in the 1970s 90-something% white, okay? Bloomfield, on the other hand, is majority Black, a direct result of effectively racism in policy. Now, what happens in that circumstance? You made zoning such that you really discern based on wealth and income and race. So arguably now, because of policy, West Hartford has more wealthy people. You also zone such that you would have less dense populations, so people could be spread out a little more. You fund the school system through property taxes, so you ensured that you had wealthy white people here who could better fund their schools, so you get a better education, which, as many people know, leads to better opportunity, better jobs, better income. So what do we see? In COVID-19, if you have a higher income, you're better educated, you have a job, so you're not an essential worker. A person like me can work from home, while somebody who didn't have the same opportunities has to go in every day. Like, let's say you're a grocery worker who then gets moved to the back of the line, right? Because we just changed policies on who's going to get the vaccine. So you're effectively taking people who have to live in denser populations, who make less money, who have jobs that force them to go in. It's not a surprise that they both get the disease or the virus more often, and then the opportunity to actually get the vaccine is a little less accessible to them, in some cases based on policy. So you can see how these connections happen, so that it's not a surprise that Black and brown people are dying disproportionately compared to white people, that white people are disproportionately getting the vaccine. And we've heard the stories about how wealthier communities are just simply having better access. It is very much connected. So with that, I'm going to turn the next question over to Dr. Edie. I'm sorry, no, we're going to Greg Jones next. And Greg, please tell us about the reflected history of the well-founded skepticism towards the healthcare system in the Black community.
Thank you, Earl, and thank you for inviting me. Really appreciate this. I'd be remiss if I would say the little kid story. One of these things is not like the other. And so one of these things is not like the other is Greg Jones on a panel with profound experts and studied experts in the medical field. So I am indeed honored to participate. I just have to be a corporate finance strategy weenie that found his way into passion about healthcare and social change and get an opportunity to talk to it. And kudos to Drs. Everett and Dr. Thomas, really learned and certainly participated with Dr. Edie on a number of panels. So I really do appreciate the opportunity here to participate. As my colleagues, I've learned from them. I'm an African-American man and I identify as Black. And so that's where some of my perspectives will come from as I talk. One of the things that Dr. Everett said that reminded me of the change or the challenges that we face. I'm currently reading a book. She doesn't need me to give her a shout out, but it's by Heather McGhee. Maybe some of you know it. It's called The Sum of Us. And what she talks about it, and I'm about halfway through it. I'll reference another book also. What she talks about in the book are a number of things that Dr. Everett and Dr. Thomas spoke to. But what's really important in the theme of this book is that little will change as relates to racism until all realize the cost to everyone. All will have to realize the cost associated with the racism that we're facing to deal with the cost and subject matter that we are facing today. So it's not just an African-American or maybe a Latinx challenge or issue. We all have to realize that there's cost associated to all of us when racism continues and sort of prospers, if there's such a thing. Getting more specifically into some of the legacies, I'd like to call attention to some of the history. And this is probably some of the only reported history that we have. There have been a number of other cases as we think about the current pandemic that we're in. But we all, maybe we haven't, don't want to make the assumption. We know about Henrietta Lacks, the opportunity or at Johns Hopkins where they used cells to create research that went on to create some pretty phenomenal and economically, I could say, well-off research used by a Black woman from the cells of a Black woman. We may know about the Holmesburg prison, where a doctor used skin cream on inmates. A number of those inmates typically happen to be African-American. J. Marion Sims, all of my medical and doctor friends know this, who was thought of up until recently, 2018, as the father of gynecology, experimented on enslaved Black women. His statue was in New York up until 2018. Earl, you mentioned 1970. This is 2018. The statue was still standing. And of course, we know very popular this in the Tuskegee syphilis experiment, right? Went on for 40 years. So these are just the public ones. And what I like to remind folks is that it is difficult to separate the past history from our current experiences. Maybe we may not have experienced some of these issues. Don't know, don't want to assume on anyone's part. But the stories and the history still pervades, and it gives us some mistrust. As I like to say, the mistrust in the African-American community, perhaps the Latinx community, the mistrust of the medical system and the healthcare system, in which I'm a part of, has been earned. It really has, based on what is done. How do we get out of it is similar challenges that Dr. Thomas talked about. This stuff is sort of like in the groundwater. How do you separate it out? The challenges that we face to try to address it. And I hearken back to say that until everyone realizes that racism is a cost to all of us and not just to African Americans, where we may be most impacted, but all are impacted at certain costs and certain experiences that we have. Those instances that are carried on from historical context sort of dictates our behavior or enhances, or not enhances, but it sets the stage for our behavior and our reactions today. And as we go out and as we talk about things and talk about, in this particular case, we'll talk pandemic, we need to acknowledge and recognize that history. Folks want to know that we recognize and understand, because when you are public about it, perhaps there's something that you might be able to do to prevent or lessen some of the same impacts that may be happening or that could possibly happen. But these are just historical issues and facts that have occurred. We all probably have had our own similar experiences where we thought that there had been some mistreatment that probably was not recorded as some of these stories are, right? We're also quite aware of what happens, with Puerto Rican women in the 1950s, where birth control pills were used to experiment on birth control pills. So there is a long legacy, and it's one that we cannot forget. It is one that certainly, as I said, we put on a different hat, we in the healthcare industry, those of us today, may not have directly contributed to it, but we own it now. And the owning of it now is, how do we gain that trust, and how do you dig a little bit deeper? How do you try to at least correct some of the ills and some of the things that are challenging? Someone might say some of the early issues all dealt with consent, and certainly it was dealt with consent. There are now things like the institutional review boards and things where people get in vaccine studies, and they certainly have to sign and understand they can opt out, which weren't the cases before. And today we're dealing with issues that may not necessarily be consent, but there still is this trust, right? We're always looking over our shoulders, and we need to understand that hesitancy and, for lack of better words, the fragility in our community, because it has been created by issues that happened in the past. So the other issue that, the other comment, and I'll close here, is I'll reference another book called Caste, Isabel Wilkerson. And she talks very eloquently of what Dr. Thomas talks about, the history of the systems in which we have created here. And we basically created a caste system that is hard and very hard to undo. And it's challenging for us. So once you realize and you understand the stark differences in some of the historical things that we've experienced, and we may be in a better position to deal with it. And my thoughts on, I tend to think solution oriented, that we must help and get everyone to understand the cost of racism and inequities affects all of us, and not just those that back in the 60s, 70s, 1800s, 1600s, 1900s that were intended to affect Black people. It affects all of us. There's a cost to all of us as we try to address or subject to some of these issues that we face today. I'll turn it back to you, Mr. Exum.
Thank you, Greg. Any other comments from our panelists? I'm just amazed you guys are able to hold back, because I can't. I have to add a couple of things. Greg was right on, but I think it's as recent as our current news, where we learned that immigrants who were being detained, immigrant women were being given hysterectomies without their consent. This is our own government policy. If you go back to when we had things like smallpox pandemic and others, people were lobbying for the Black community because they weren't getting some of the assistance, some of the mobilization that the government put in place. This my source is the 1619 Project, by the way. The mobilization to try to address these things, the money wasn't spent in the African-American community because policy experts said that the genetics of Blacks were such that they were going to be extinct anyway. Outside of slavery, there was a common belief in the medical community that they weren't going to survive anyway. So why invest that money in the Black community? Then the last thing, this is not a history book at all, but I fashioned myself a bit of a statistician, and there's a book called Dance with Chance. And it's all about statistics. And when I read that, it confirmed for me that I don't like taking medicine, because it talks about how they do clinical trials. And for most of the medicines that have been released during my lifetime, the clinical trials tended to focus on young white males, but certainly not Black males. But once the FDA can release a medication based on those clinical trials, and then then even if it wasn't used on children or Black people, it then can be administered to Black people, then they monitor as it goes. So if it hasn't been tested on you, it seems to me that, you know, you're going to find out sort of in action whether this works for you or works against you. So these are some of the reasons why people may have reluctance at sometimes in putting their full faith and trust into our current medical system. So since nobody else had something, I had to give them. I can't hold back. You guys are amazing how calm you can stay on the discussion. I do have a couple of questions here.
Earl, may I make a quick comment?
Sure.
Regarding the smallpox after the Civil War. As you can imagine, the enslaved people were freed. They were just let go. They had nothing. They had nowhere to go. They had no food to eat. They had no clothing. They were just let go. And now enter smallpox. They were on their own and they were dying in great numbers. And then, you know, because they're an inferior species, they're going to die off anyway. Well, come forward to COVID-19 and we see Black people are dying at a much greater rate. And it's because they have these comorbidities. You could almost kind of look at that as being, you know, they're constitutionally weak and they're dying off. And there was a theory among some of my friends that as soon as they realized that it was Black people and elderly people who were dying from COVID-19, that's when the young white folks are ready, you know, you're usurping our rights by not allowing us to go to nightclubs and da-da-da-da-da-da-da. You know, I mean, Black folks are going to die off anyway, so.
Thank you, Dr. Thomas. There are 3 more questions, but I think Dr. Eady may actually address a couple of those in his discussion. So I'm going to hold off and ask them at the end of what Dr. Eady is going to share. So Dr. Eady, how should we navigate our healthcare system through this pandemic? And specifically for people of color, what should be key considerations for them?
Yeah, so, you know, I'd start off by trying to make it simple. And I'd just say we should navigate this current pandemic as people of color with 2 things, with caution and with courage. And so as Dr. Thomas, as all the panelists prior to me speaking said, I mean, it should be absolutely no surprise that communities of color were hit the hardest by the pandemic because of its social vulnerabilities. The proof is that people of color are 2 times more likely to be infected, 3 times more likely to be hospitalized. And then, of course, unfortunately, we've all in some form or fashion experienced this directly or indirectly in our lives, 2 times more likely to die from the virus in comparison to white communities. So the COVID-19 pandemic's impact in the US has merely illuminated, and I underscore illuminated, long-standing inequities by race, ethnicity, and income. So let's talk about the first one, caution. So we're still in a pandemic, clearly. And although the vaccine provides what I consider to be, and oftentimes people refer to as a light at the end of the tunnel, with caution, we must understand that because of these so-called variants and mutations, that may reveal to us that the so-called light at the end of the tunnel is really a train heading our way. And when I say our way, I mean headed toward Black and brown communities. And so be cautious about your interactions with the healthcare system. For example, virtual care is a safe option where applicable. And whether one is vaccinated or not, I'm going to try not, I spend my entire day in the last 3 months talking about the vaccine. So I'm going to, unless there's a question, I'm going to sort of steer away from that. But I've got to say, whether one is vaccinated or not, we must continue to wear masks, distance ourselves, and practice proper hygiene. As the country begins to open, we need to make sure that we, including our friends and family, are not responsible for creating a so-called super spreader event or a COVID hotspot. And we talked about hotspots just a second ago. And let's talk a little bit about courage, which is a little more exciting to me because this represents, as Dr. Everett alluded to, this represents the transformation, the switch, the change that we are responsible for undergoing. So this is when and where I think we need to have the audacity to take control of our own health and not surrender it. And I'm saying this as a CEO of a healthcare system and a physician, not just surrender ourselves to an individual or a healthcare system. This conversation that we're having today, and thank you very much, Earl, for sponsoring and hosting and having the audacity to bring it forward, it should not be on occasion. It should not be instigated only secondary to anomalous times such as this pandemic, and it certainly should not only happen in the month of February. We all have the talent we need. And I've been here for almost 3 years now, right here on this panel and right here in the state. We can solve all of our problems in and of ourselves. We just need to come together and do that. We need to take control of our decision making. For example, last May, remember that's right when the pandemic really was in the thick of things in our state, we published an op-ed that in the HBJ that was entitled "The Unintended Consequences of the Stay Home Campaign." In that, I was trying to remind or inform the state that we have seen in emergency departments a 50% decline in life-threatening illnesses in the emergency departments across the state. These are illnesses, serious illnesses, such as strokes, heart attack, heart failure, appendicitis, gallbladder disease, and the like. And so, so we all know that there's no way in the world that COVID cured 50% of those diseases. So what happened to them, and did they just disappear? And then came, and if I sound like I'm passionate and frustrated about this, because I was and I still am, then came the ad council's commercial, which said, I mean, it literally said, if you remember it on television, it said, whether or not you have COVID-19, stay at home. Whether or not you have COVID-19, stay at home. And you know what happened? Without question, our communities took it literally. We listened. The result, an increased number of at-home deaths. Where? In our communities. And then ladies, and I always make it a point, I think Dr. Everett or Dr. Thomas remind us that 70+% of our households are led by women, and the healthcare decision maker in the household is the woman. But I have to remind the female audience that we must have the courage to have the audacity to make our mammogram appointments in the midst of this scary pandemic. Because remember, 35% of African-American women are diagnosed under the age of 50 with this breast cancer that's different than others that we see. It's more aggressive, it spreads faster, and it yields greater than a twofold mortality in comparison to other women in this country. We must have the courage, I would suggest, to make health maintenance a priority. We must have the courage to make health maintenance a priority. Keep your scheduled appointments, still get your annual physicals, and go to the emergency departments for the same reasons that you went to the emergency departments prior to the pandemic. Let's make sure we have the courage to always use a critical eye when it comes to any medications we're offered and any procedure we're recommended. Again, it sounds like an oxymoron because we pay our bills at Trinity Health in New England by you doing that. But we as a people must make sure in the midst of us having this insecurity or this hesitancy, we must begin to question everything about the aspect of our health. And of course, there's been a lot of conversation about the vaccine. I'm not going to get deep into it, but I'll say that the same amount of scrutiny that we have been talking about the so-called hesitancy, which I think we should transition from and talk about other things related to the vaccine. Just because we are referred to a physician does not mean that we shouldn't scrutinize the choice. We need to make sure that the choice is right, not only for us, but our families and our communities. And then I think your second question was about advice that is specific or particular to African-American communities or communities of color. So I'll say a couple of things to that. So the narrative, I would suggest that we're dying at a higher rate because of us, because it's our fault. It is, I'll say, garbage. The narrative suggests that we're dying at a higher rate because of our skin color, because of our genes, because of comorbidity, because of our diet, because we're obese. And the truth of the matter is, and this may be controversial, but this is my position, it's because of systemic racism. The systemic racism that's created a marginalized and vulnerable community. As a matter of fact, I often say, and I will continue to say, as controversial as one may seem or may consider it, I will continue to argue that systemic racism should be considered a pre-existing condition. Listen to me. Systemic racism. When you go to a physician's office, we take what's called a past medical history or history. We ask you what diseases you've been exposed to, what medications you're taking, what kind of allergies to medications you may have. Do you smoke? Your social history? Are you married? We ask about your surgical history. We ask about your family history. And what I'm suggesting is that one day we should be able to say comfortably, and it must be accepted by the insurance companies, that a pre-existing condition as an African American is just that, is systemic racism. Because when you do the research and you understand why we have these so-called comorbidities, you'll understand that the system is marginalized and pushed us forward as a community that predisposes us because of this racism to just that. But with all that being said, and I don't want to be super passionate here, we'll save that for the Q&A, just a couple more points and I'll yield the mic back to you. We still have work to do, both collectively and individually as a community. And so what may you ask we should be doing? I think we should make sure that our primary, and please listen to this, we should make sure that our primary care providers know us. They know our culture. Otherwise, with all due respect to the physicians in the audience and on the panel, they won't know how to properly treat you. And that's the bottom line. They're going to make decisions, as Earl alluded to, that may be choosing a medication that's not in the best interest of you or your family. Make sure you choose the hospital or healthcare system wisely, not by name, not by size, but by the quality of care. Let's think about this for a second. Think about think about how we choose our cars or our clothing. Shame on us if we apply more intel to choosing the clothing or the car instead of the healthcare system or the physician that we get in front of and we trust our lives to. Remember, hospital quality scores are public information. So you do the research and you decide based on the quality of care and the patient experience where you should go, even if it's an extra 20 miles away from your town. Ask questions and demand answers. And if for some reason your response, the response is inadequate, then go somewhere else or go someplace else. Don't tolerate that. It's time for us to think differently, to take charge of our healthcare and to make sure, I mean, listen, someone alluded to the first African-American physician who, if I remember correctly, this was back in the 1800s, the late 1800s. She, I believe, practiced somewhere in the Northeast or up north. She went down to the South where her skill set was needed. That's the type of courage that we all must have, regardless of what position you play in life. Also remember that health and wealth often go hand in hand. Health and wealth, where you see the wealthy, you see the healthy. And if you don't believe me, just look at the hot spots of COVID-19 and go to any massive disease that has affected a large number of people in this country. And the most common cause of bankruptcy in America is medical bills, not by coincidence. Over 66%, if I remember correctly, of bankruptcies in this country are due to these medical issues like being able to pay high medical bills or high copays or due to lost time because you're an essential worker. So it's time for us to come together as a panel, as a people, as a state, and advocate for things like getting rid of communities where there's a large percentage of residents that are underinsured or uninsured. And finally, I'll just end with a couple points on the vaccine, just a couple. This is not about vaccine hesitancy. I honestly, wholeheartedly believe. I think this whole narrative around that, now listen, here's what I mean by that, because I don't want to start any controversy. And I don't want people sending me emails and bad-mouthing me like it's been happening since I've been a part of this whole vaccine advisory committee. But healthcare hesitancy in the brown and black community has always been here. And as Mr. Jones said, rightfully so. So let's not talk about that because that's already there. We can address it through education, through explanation, what I like to refer to, but it's something more important than talking about the vaccine hesitancy. To me, in my opinion, more importantly, we should talk about vaccine equity and we should talk about vaccine access. Because when we put those in the forefront of our conversation, you will then understand that people are coming from all over the state, the healthy and the wealthy, to the north end of Hartford. Why? To get a vaccine. While the people in that area who have, and you'll hear more about this in recent or upcoming conversations and articles from the governor's office, but these so-called high social vulnerability indices or indexes in certain communities, I mean, they don't have access to the vaccine, and it's not because of vaccine hesitancy. I've got the data to prove it. So with that, thank you, and I will yield the mic back to you, Mr. Exum.
All right, Dr. Eady, thank you very much. Okay, as usual, I'll give the any panelists who have anything to say something before I turn to some questions. Greg, you're on mute. Greg, you're on mute if you're talking.
Told us at the beginning not to do that, right? So I just want to echo Dr. Eady's point here again. And this notion and discussion on vaccine hesitancy, we should really be talking about what he said, vaccine access and vaccine equity, because the hesitancy was taken in polls, theoretical polls, before we even had the vaccine. Right. And so we took the history that I just talked about. We took the history and folks says, well, I'm skeptical. I don't know whether I'll take it. Now that it's available, we need to be talking about how we get access to it if you want it and giving you space to make that decision. So I would encourage all of us they're still in the popular press talking about hesitancy and talking about Black folks and Latino folks about the hesitancy. And it's almost put us in the same box as the anti-vaxxers. That's two totally different buckets of people. So I think what we should be talking about is access and equity. And if you just take a poll of your friends, now it may be non-scientific because we all associate with folks that may be similar minds and so forth and all, but just ask them. Your percentages probably will be different than what some of the historical polls have indicated way back at the beginning. So I want to encourage us to think equity and access and give folks the space and time, which I think that will catch up. But the more that we spend talking about this hesitancy and thinking that African Americans and Latinos are some different mindset, we know the history, right? We can repeat these things, these 5 different historical things. Earl, you mentioned one most recently. We know that history, we know what that is. We understand that. But now we want to talk about how we get equity and access so that we can eliminate and avoid some of the issues that we faced in the past.
I mean, it's no different. I think when people say they're not going to take it because they're afraid, because they're hesitant. I mean, the more they tell us that, the more we believe it, and it's really them blaming us as if we are at fault because we don't want to get vaccinated. Greg and I, we've done multiple conversations. Dr. Everett and I have done multiple conversations where we poll at the beginning of the educational session, we poll at the end of the educational session, and those who sort of decide that they're not going to take the vaccine, our conversion rate, this is data. This is an audience that we did not choose, which makes it relevant from a scientific perspective. Our conversion rate is north of 80%. And the reason why is because they just deserve to know and they deserve to learn more about it in the way that they want to learn. And we have the responsibility as so-called healthcare professionals to take the information to them. But don't call them hesitant. Don't call them non-compliant. That's what I was taught in medical school. When you're taking care of Black and brown patients, they're not going to come back for a follow-up. They are not going to take the medications. They're not going to follow instructions. But this Black or brown person is smart enough to know that they need transportation to the appointment. They need to understand the medication, which you didn't spend time explaining to, which is why Mr. Exum talked about his anxiety around taking the medication. I mean, we have to give more respect and empower more ourselves and our community and demand that we be treated fairly and equally. And that's just not happening today. But I'm pretty sure I'm getting passionate. You wound me up, Earl. I'm pretty sure that
took me a while, but I got you.
I know, and my wife told me not to talk a lot. But this conversation is certainly going to, I believe, fertilize and grow into product, a fortified conversation that I hope and pray that as long as I'm in Connecticut, we have this much more often than annually.
And may I just say, to your point regarding vaccines, this past weekend in Philadelphia, the Black Doctors COVID-19 Consortium held a 24-hour vaccine clinic, and it was jam-packed. People waited in line for 10 hours, some people, and it was very successful. So if you take it to where the people are, and if they need explanations, give it to them, they will partake.
Yeah, I'm just going to add on and say this. This inability to think both and think that it is an either or is just a continuation of white supremacy and structural racism in our society. Bottom line, people can both be hesitant and both want the vaccine. You have to provide the access. We can do two things at one time. We can walk, chew gum, we can probably run and jump, all of these things at the same time. The bottom line is you cannot blame and say, oh, it's about hesitancy. That's why African Americans and Latinx individuals haven't gotten the vaccine, when you haven't provided the access. So I just want to echo for all who are listening, when people bring out hesitancy, ask them for the data, because it doesn't line up. Now, that doesn't mean that we don't need to address it. We do know, as Greg said, we know the history. So we need to prepare folk. But when people in the beginning were saying, I will not be first, that did not mean they were saying, I will be last. Those are two different things. And Yarrow, you got us wound up now. So
Yeah. Look, it took me, like I said, it took me a little bit to get you guys going. There is, Jen, there is a question. I lost track of the questions. Maybe you could help me on education. I'd like to get that question on the table, because I don't think that one has been answered yet. Oh, here we go. What should our local education system do or start to do today? For any panelists.
well,
So I'll take a, as I said, one of these things is not like the others. These are trained doctors and researchers, and understand, give me my passionate corporate spiel. I think we need, education is a place that I started to play in, only because of, I believe it is the foundational element that creates a lot of these disparities that we face, right? When we look at the education, I think we need to focus on smaller class sizes. I think we need to focus on funding levels that are equitable across the state. Education is not just a local resource. It is a region and a state resource. And because you live in, West Hartford, or better yet, live in Avon or whatever else, and you have a different real estate funding model for your education schools, therefore they can get more than the kid in Hartford, we've got to fix that. And we also have got to fix the ability to serve students of need based on what their abilities are. You got some schools that are populated heavily with kids that have special needs or special accommodations, that have different learning styles. And they may be in classrooms that are very large, and they don't have the specialized teachers to accommodate them. I think if you look at the funding levels across the state and look at education being a state resource, because I live in a suburb doesn't mean that the state won't benefit from somebody that lives in Hartford. We've got to look at this as a general asset. And I think those are things: smaller schools, more teachers around the level of expertise to help and support the kids that we have, and a funding that supports all kids in the state.
I'm a Southern raised Baptist Christian, so amen, Greg. And I will add that from a 1619 project perspective to what Greg has offered, a year or two ago, I think it was, we passed the mandate of African American studies being taught in our public schools. And I think we need to further that and be very clear, no matter where we live in this state, African American history, Black history is our history. We need to incorporate it every day in every learning, in every way. We need to fight and become anti-racist and thinking through, if it is vacant in our education, how are we adding it in? And it is the responsibility of all teachers, not just teachers of color.
You know, Dr. Everett, I sometimes I struggle with, I wonder if Black people are ashamed of being Black. I realize that's not a topic, Earl, I apologize, but I mean, at some point, the psychology behind that, the demonstrations that some of us have the privilege of witnessing from our brothers and sisters, it lends to that. And I just wonder, psychologically, and I'm sure the genius Dr. Everett has a great response and answer to it. But I just wonder, how do we address that? Is it real, first of all, and how do we address it if that is the case?
Well, now you're getting us into the forms of racism, and I'll be real quick in just addressing that point. One form of racism is internalized racism. And there is definitely an existence in the Black community of internalizing that which we have been told has been instilled in us, and that which shows up in our media and in our policies, that we are not good enough, that we are not right enough, that we are not the right people, that there's something wrong with us. And quite frankly, we have to begin to dismantle that within ourselves, within our own community, and we need to dismantle it externally. I don't think by and large that we are all ashamed or that we all have a problem, but there are a lot of ways in which internalized racism shows up and shows up in us that makes us not show up all the time for who we are and what we need as a community. So one small example that I give of this, I am a professor, so I say this all the time. I used to say ma'am and sir all the time. It didn't matter who you were. You could be 82 years old or 8 years old, and I would probably say yes, sir, no, ma'am. When I realized and connected that that was really rooted in slavery and who was supposed to get respect and who didn't, I immediately took that out of my dialogue, because that's internalizing the racism that has existed in our society forever. So that's a small thing. The way we need to get at this, both from all of the forms, is consistently questioning how it shows up within us. What can we do to dismantle the racism that is within, around, and throughout our communities? But we don't even have more time to talk about this. You got me wound up right at the end, Dr. Edie. I appreciate you for it, though.
Well, listen, we are coming to the hour here to end, and I love to start on time and end on time. But since I am the host and the moderator, I will take the last word on that question. And it's only to reiterate what you've already said. If you study our history, the people who developed our curriculum, one of whom was a Yale person, was a racist. They intentionally left out the fact that all of us originate in Ethiopia. We know that from genetic testing, and we know it from archaeology. Libraries, the first education system, the first democratic governments, the first agriculture, the first domestication of animals, the first written communications, the first art, on and on and on, came from Africa and emerged from Ethiopia. I didn't know that until I was in college. It's almost that if you go through the education system today, you will be taught effectively, implicitly or explicitly, that white people are better than Black people, because we highlight all of the great accomplishments that were primarily done by Black men. But when you do your research, it doesn't. Everyone's made contributions, but we focused on one. So it leads to some of the things you talk about. And then when we do policy, that's the psychology with which you do policy. And I'll just say this, I was just on a panel talking about the new legislation that they're introducing on vaping, and they want to take menthol out of cigarettes, arguably because Black people have been targeted. The problem is, once you take menthol out of cigarettes and you make it inaccessible, there'll be a Black market. And that gives you the opportunity now for Black people now to be confronted by police. It goes on and on, the systemic issues. But we won't throw money at fixing the problem of health and cigarettes, which, oh, by the way, states took $200 billion from tobacco and then handcuffed themselves on their ability to actually address the issue. We won't put money into that. But if people's foundations are crumbling through no fault of their own or anyone else, everyone in the state has to go figure out how to solve that and send some money. Some of that is rooted in the education we got on who should be helped and who should not. So it is all intertwined. If you didn't get that from this program, I'm just honored to have the opportunity to share some of this information, honored to have these panelists and be able to host and moderate, honored to work with Jen Matos in the Noah Webster House and West Hartford Historical Society, and with Jen Evans from the West Hartford Community Interactive. It's really a privilege, and also to be part of the community conversations, because the great thing about West Hartford is it is a community where we can have these type of intelligent conversations, learn, grow, and change. So I want to thank all of our panelists. Again, it's been a privilege to have you on. Thank you for accepting our invitation, and I believe our community is going to be better for it. And happy Black History Month, everyone.